every connective tissue cell, guys. Connective tissue is a huge, broad range of tissues. You know, we've got, if I go through the four main types of tissue, which we'll do in another chapter, but just hear me out right now. We've got epithelial tissue, which is a lining, both inside and outside. So the inside of your blood vessels, the inside of your organs, and the outside of your body, that's all epithelial. Then we have connective like this. Connective is a huge, the biggest range of tissue, actually. You've got bone, cartilage, ligament, tendon, blood, lymph, fat, and all that regular tissue that goes in between all the organs. If you've ever opened up like a deer or anything, all that regular tissue, everything that connects everything is connected. And then we've got nerve tissue, right? And then muscle tissue. We've seen what muscles look like. We know a little bit about nerve tissue just from knowing that we have nerves that connect everything. But connective tissue right here in a matter of bone is the biggest of tissues. So of these connective tissues, guys, they're all coming from stem cells, which in this case are going to be called osteogenic cells. That means that this is a stem cell that's going to become a bone cell. That's what that means. So we're looking at a little bit of a life story. Stem cells are going to become osteoblasts in this case that will make the bone. And then osteocytes will be what they turn into. So after they make the bone, it's like they graduate and they become osteocytes. So just know those three in order, right? That's what they start off. All bone cells will start off as osteogenic cells. And I'll put that picture there, you know, I added that picture the other day. We have an osteocyte. If you can see that, we'll blow it up for a second. Sitting in that little lacuna where they live, it's basically just a little pocket. So if we're looking at this osteocyte right there, it's sitting in like a little cavity between the lamella. Each of these, you know, beige units is a ring of bone. It should be going on a circle. It's just partly a picture. But there's an osteocyte. It used that one osteocyte right there, and that one, and that one, and that one, all these different ones. They used to be osteoblasts, right? So they make their bone, they basically surround themselves with the bone that they make. So they trap themselves in the bone that they make. And then once the bone is mature enough and hardened enough, they're now called osteocytes as they live in and maintain that bone. So yeah, an osteocyte is just a mature osteoblast, you could say, right? And then what was the osteoblast at first? Before it became an osteoblast, it was a osteogenic, right? So basically an infant, you know, a teenager or adult, and then a mature adult. That's what we're looking at, the three cells in that order. The fourth cell, the osteoclast, is something altogether different. So the osteoclast, the next cell we're going to look at is going to be something altogether different. It's not related to these three. So know those three in that order. Wear out the marker. An osteoclast, guys, is going to be a cell that kind of eats away the bone or molds the bone. So think about if I throw you just a big old stone, right? And what does an artist do when it turns a chunk of stone into some kind of a statue? How does that work? They basically like chip away, you know, what is, if they're making a horse or something, right? They chip away what's not the horse, right, in their mind. So when we see an osteoclast, we're going to take basically a chunk of collagen like this, or a chunk of bone, and then make it into the shape that we want. So the osteoclast is something derived more so, it's still from a stem cell, but from a different. it's going to be derived from a white blood cell type of stem cell. It's going to eat other cell. So an osteoclast would be something like this. It'll chip away, right? Little by little until bone becomes the shape that we're used to. So we get our normal shape of bone like that, something like that. Right? So that's what an osteoclast would do, where you saw me erasing what was not part of the bone. That's how we get the shape of our bones, is from the osteoclast. So it's going to have enzymes, acids that will attach to the bone and then liquefy the bone and then pull the bone tissue out. That's what an osteoclast will do. So it's, in part, an osteoclast is mostly good because it does mold and shape all of our bones. But realize if osteoclasts are out of whack a little bit, if they do too much, they'll certainly steal too much calcium from the bone. And that's that case study you had on your test where we heard that sometimes if our blood levels of calcium are low and we need some calcium to put in the bloodstream, then we're going to call upon an osteoclast to pull some calcium out of the bone to put in the bloodstream. That's that feedback loop question we had on the test. So just know osteoclast is a whole different animal. It's not related to building bone. It's related to shaping the bone. But we call that resorption. So there's that keyword for osteoclast, resorption. Okay. So, okay, we've spent, I don't know, 5-10 minutes on bone cells. If you had these in matching, would you know which one's which? Would you know which one is the stem cell? Would you know which one builds the bone? Right? And would you know which one maintains the bone, which is the osteocyte? Now we know which one resorbs the bone and is used to help blood calcium levels. If you saw some random question about which bone cell will be used to reestablish blood calcium levels of these four, which one would you pick? The osteoclast. So it's not written here because it comes in another slide, but if you want to add this to your notes, the osteoclast is the one that helps reestablish or helps to balance, homeostasis, blood levels of calcium. That's what we're looking at. And remember, the magic of this, guys, is, okay, you're telling me this today, but how am I going to remember that on, test day? Well, you probably won't, but the chances that you will are directly related to the chances of how you learned this, how you reviewed it. Did you just hear it today, one time? Or did you hear it like by yourself? Did you go home and study these 4 cells again as a little goal and review it like maybe once a week, something like that? So you got to make these concepts. Right now, this is a concept right on the board. Review these concepts as you go home and then test yourself, little quizzes to yourself, meaning blank sheet of paper, note card, write these 4 down, and then out of your brain, what do the 4 do? That's what I'm talking about, active study, not just highlight your PowerPoints. That's what most people do. And it's never going to work out like that, guys. It's too much information. You got to write stuff down to get it to sink in your brain. So you'll find yourself, if you can make note cards in this and you can write these down and what they do, you're going to remember them for the test most likely. If all you do is highlight it or just hear it in class without ever reviewing it at home, you're probably not going to remember. That's just what the bone cells look like. It's not warm in here. There's a stem cell, there's a blast. A site has a little maturity to it, look at it showing off. Right. There's osteoclast. You'll never have to see pictures of these on the test, but it's just see the osteoclast a whole different kind of cell. See what's going on. All right. Okay, so here's our matrix. Never mind the words in red right now. Pay attention to whether it's organic or inorganic. This is what makes the substance of bone. Look at the keywords, guys. What is organic? It's going to be the collagen. How do we know collagen is organic? Because we learned that collagen was a protein. And proteins were one of our organic compounds. So let that sink in. What it means to be organic again was something with carbon and hydrogen. So that means that all the organic compounds that we studied, which is the proteins, carbs, and lipids, right? Those all have carbon with hydrogens. That's why we know they're organic. The inorganic portion is going to be the minerals, right? Calcium and phosphate. If you write, not that you would know this unless you had chemistry somewhere, but if you write calcium phosphate, there's no carbon, right? We have a calcium, phosphorus, and oxygen. There's no carbon, so that's inorganic, right? Same with sodium chloride, right? That's a metal, that's a gas. Sodium chloride, there's no carbon there, so that's inorganic. So just knowing what those words mean from chapter 2, again, inorganic things are going to be minerals. This is what's going to harden the bone. So it's the collagen that gives you the density of bone. All this black stuff I just drew on this picture, that's all the density of bone. That's the collagen that became hardened, right? If this were osteoporosis in this bone right here, it'd mean that I would take that density away and I will put holes in the bone. That's what osteoporosis would be. I lose the density of the bone, the thickness of the bone, right? So yeah, and the keywords, guys, it's the organic portion that gives you the collagen. With the collagen gives you the density, and then if you flip that without the density, you get osteoporosis. Thickness of bone. If I don't have the inorganic portion, which is the mineral salts, the calcium, then I'll lose the hardness of bone, which becomes osteomalacia. So there's two forms of this matrix: the actual substance or the thickness of the bone, the density, that's the collagen. Then there's the hardness of the bone, that's the calcium phosphate. So know which one's which, know which one gives you the hardness, which one gives you the density, know which one's organic or inorganic. Again, I'm trying to point you to the kind of questions you're going to get on the test. So this is another 10 or 15 minute study goal for you. Right? Today, go home tonight or something, know your 4 bone cells, know which 2 parts of the matrix there are, which one gives the density, which one gives the hardness, right? Which one's organic, which one's inorganic, all that kind of stuff. So you can either memorize the slide or you can think about it. That's what I want you guys to start doing is thinking about it, making it make sense instead of memorizing it. And I'm not worried about the words in red. There's no reason to know those to me. If you ever see it in Connect, just remember that the osteoid with an O is organic, if that helps. Because you probably will see it in your Connect assignments. All right. So there's our review of our first 2 big topics for today. All 4 cells, and then what's organic and inorganic of our matrix of bone. And then notice I threw the disorders in there because we're going to see that. I'd just like to have you guys relate that right away. Any loss of density. So if you get any question, loss of density of the bone causes, this is osteoporosis. Loss of hardness of bone is osteomalacia. And yes, they can both relate to each other. They can. Clearly, women, especially that get osteoporosis, do have somewhat of a lack of calcium. They really do. It's because their lack of estrogen doesn't have them absorb the calcium. So that's a hormonal thing that kind of hits both. But you cannot diagnose osteoporosis without saying it's a loss of density, for sure. That's the main problem. Calcium is a part, yes. Let's put it this way. Obviously, if you lost the density of the bone, you've lost some calcium, right? Obviously. But that's the keywords I need you to pay attention to. All right. So another thing about growth, we have two types of growth here. Growth in length or growth in width. So here's another thing you got to know the difference of it. Growth in length comes from inside the bone. Again, it's underlined, right? Growth in width comes from bone growth that's outside the bone. So little keynote here for interstitial, this is our growth plate. Growth. Interstitial is the growth plate that we saw last time. Where bone grows in length, right, from within the bone. Appositional growth, the width of bone, really just comes from your genetics. The style of bone you have, the thickness of bone, but it also comes from what do you do with that bone. People that, you know, through life, as the bone maintains itself, people that have more hours, you could say, with stress on certain bones will develop a thicker bone. So let's say you're a professional tennis player or a professional baseball player, and you're right hand dominant, right? And you're hitting that baseball from 100+ mile an hour serve. Well, the energy of that ball hitting the bat, converting energy into your arm, imagine how much stress that puts on your arm, right? So stress on a bone will build a thicker bone, for sure. Or professional tennis serve. If you've ever, has anyone ever returned a professional tennis serve in this room? I'm by no means a tennis player. So I just jokingly played tennis with my buddy in college who was a pro player. Let me tell you guys, when those, as soon as his racket's in the air, the ball is already in your body, basically, is how fast it is. So when the ball hits that racket, it's so much energy coming in. All that stress energy coming into your arm is going to build a thicker bone, so you learn how to, and muscle. So yeah, that kind of thickness comes from stress, whereas interstitial growth comes from the growth plate. So two different types. And at the bottom here, real quick, we want this word, ossification, to make good, healthy bone. Calcification is just calcium going anywhere. It may go to the gallbladder for gallstones, the kidney for kidney stones, the arterial walls for arteriosclerosis, or deposits in the lungs, deposits around the joints. So calcium going wherever it wants is not a good thing. That's what's called calcification. If ever you're in practice somewhere, guys, and you hear the word calcification, it's normally not a good thing. When you hear the word ossification, that means calcium is being placed into the bone correctly. So just knowing the difference between those two words. Okay, here we go. Beginning in 8th week of development, we get our two types of bone growth. So here we go. Using what we learned last time, these two terms point to the two processes that take place to build your skeleton. One of these, the first one, is going to build the flat bones of the skull and sternum. That's intramembranous. Just think skull and sternum. Why do we pick on the skull and sternum? What's unique about these kind of bones? They're both very flat, right? So we like to call those membranous bone because they're flat like a membrane. So skull and sternum, and even the clavicle in this case, is going to be formed using intramembranous ossification. Everything else is going to use endochondral. So two types of test questions. You're going to see what endochondral, where endochondral is different, yes. But for the first question, you want to know which type of bone is made with which process. So if I gave you bones of the arm and leg, which one would it be? Endochondral. Bones of the spine. Endochondral. Bones of the shoulder and hip. Endochondral. Everything else is endochondral, right? Only what's in the intramembranousness. Skull and sternum. Makes it really easy. The flat bone. Skull and sternum. I should say flat, straight, and 130 bones. Because oddly enough, the ribs are endochondral, even though they're kind of flattened. But the skull, sternum, and clavicle is intramembranous. So that's our first big step right there. The next step is just to see what are the major steps in each of these. So here's what you need to know about intramembranous. We start with stem cells. So in your notes, right, make sure you know that the mesenchymal cell is a stem cell. And again, if you're not really comfortable with talking about stem cells, like what, since they're so kind of random, a stem cell is just a very generic cell. That's all right. A stem cell is something that hasn't been told what it's supposed to be yet. So if I gave you an idea of a stem cell, guys, just a generic stem cell could become a ligament cell, so fibroblast, a tendon cell, another type of fibroblast, a bone cell, a blood cell, a fat cell, a virus connected tissue cell, a lymphatic cell. They could become a lot of things, right? So mesenchymal cells are just generic cells that will become whatever they need to become through key whenever they're put in the right environment. So if I take a stem cell, even today, the stem cell research that's going on, works every time. You harvest a stem cell like you come up with placenta. You put a stem cell in bone, what does it become? Bone. It knows its neighborhood, it knows its environment, so it becomes bone. If you take a stem cell and you inject it into a ligament, what does it become? Ligament. You inject it into a tendon, it becomes tendon, right? So this is the beauty of stem cell research. We've seen huge advances in rehab, sports injuries, with tendons and cartilage being rebuilt using stem cells. So this is the generic cell. So we're going to see this show up in both types of bone frame. Why? Because that's the base material that you need to build anything. For all these research things that are going on, where they build these artificial hearts and stuff like that, they use stem cells, artificial organs. Where it's headed. Anyway, we know we have to build some collagen because that's the base of all bone. So you'll see collagen and mesenchymal cells, these two together, being present in both of these formations. You can't build bone without it, in other words. So this is a short kindergarten version of how we make bone with intramembranous. We start with stem cells, they make collagen. Those stem cells will turn into what? Osteoblasts and osteocytes to make the bone. So just know that sequence right there. And some pictures to go along with it. There's your, whoops. You don't have to know the picture, but here's your stem cells in the blue. Look at these little slivered cells. Those are your stem cells. Those stem cells will become these osteoblasts that we see in the center. Those osteoblasts will make more of the matrix there, spitting out some matrix. So let me get, there's so much going on in this picture, but it's not related directly, but you can see the stem cells, right? The flattened cells here in the purple. And look at these long fibers. Those are your collagen fibers, right? Long fibers. And in the background is just some water. There's your matrix of bone. The osteoid that's being shown, that's going to make more collagen. What they're not showing in here is the hardening of the bone. They're not showing that hydroxyapatite part of it. That will come later. And just imagine these osteoblasts spitting out little bits of collagen and little bits of calcium phosphate to make more bone. So now they make bone, they trap themselves in it like we saw. They just start making more and more and more. And eventually you get this flat bone that we call the skull stone. Okay. Moving on to the next one, endochondral. All we did, we took the same mesenchymal collagen we started off with. Now we add cartilage to the mix. Instead of going straight to bone from collagen, we go to cartilage. So no, this is the second thing I was telling you about. Knowing the difference between endochondral and intermittent means that you know that there's cartilage that's used in endochondral. Meaning that collagen, yes, is a protein, but what's a thicker protein? Cartilage. So now we're taking a thicker protein matrix to make endochondral bone. So this base bone, this model of cartilage, builds a stronger bone. Why? Because this bone needs to hold more weight. Endochondral bone, like the bones of the arm and leg and spine, will clearly hold more weight, more mass, more load, will do more than what your skull does. We don't really do much with our skull, right? It just sits there, as well as our sternum. We don't do things with our sternum either. But we do things with our spine every day. We do things with our arm and leg every day. So when it comes to that kind of bone, it needs a tougher matrix. That's what we have cartilage for. So just know, before we become full mature bone in endochondral, we use cartilage as a molding before we ossify it, before we harden it. I use this comparison, maybe it hits home for some people. Think if you were, if your job was to build a road, right? Think of the materials you might need to build yourself a driveway compared to building yourself a piece of the interstate. Would everyone agree, even though we're not trained in roads, would everyone agree that the interstate roads are a lot tougher than your driveway? Right? Interstate roads and bridges can hold tons and tons of weight. Your average driveway, hell no. You know, if you put an 18-wheeler, a whole 18-wheeler times 100 18-wheelers in a given mile of road, you're going to need more materials, more dense material in the interstate road than you will in a driveway. So that's why we say we need a tougher matrix of cartilage to build endochondral. Plus, look at the likeness. A chondroblast is a cartilage cell, so we should know that cell too. Look at that chondro in there. That's telling you that we're using cartilage. So don't forget that association. You might just get a question, which of these bone formations use cartilage as a model? Let's go back. If you have a choice on a question, which of these bone formations use cartilage as a model? There you go. Endochondral. Perfect. And don't forget when it starts, about the 8th week of development. Start making yourself a little skeleton. So let's just say between the 8th and 10th week of development, you know, roughly the second or third month, first trimester, you're going to be making bone. That little baby is going to be developing a skeleton, but it will not be fully hardened yet. You'll have basically a full cartilage skeleton. So your whole skeleton is going to be cartilage, right? Except for the bone in the skull, which is going to harden first. Doesn't that make sense? Shouldn't we harden and protect the brain first before anything else? Yes, we should. So that's why skull, right? And even the sternum protecting the heart. You know, the two most important organs, brain and heart. So shouldn't we protect those two organs first, right? So that's why the bone, these will harden first, intraminimus. Endochondral will take longer to harden. So we'll see that come up. We'll see that play out in a second. That's why I always say, if you learn the design and logic behind things, just, you know, it helps to learn it correctly. I remember being in college, I was so much in a hurry. So many other priorities besides being in class. It's just terrible. Terrible for maturity. You know, the idea of college, I went to Ole Miss. So I was from New Orleans, went to Ole Miss for stupid reasons. Oh my God, so stupid. When I think of myself that young, let's just put it this way. You know, my whole family went to LSU. So the recruiter came to my high school from LSU, the recruiter from Ole Miss. She was just so darn cute. I thought, why not go to Ole Miss? You know, it seems like a nice college. Yeah, terrible reason. Yeah, very terrible reason. But when you're there in college, you don't always pay attention to what your teacher's saying. I realize that. But when I'm giving you priorities, you definitely want to make note of them. We're going to have more questions on endochondral because there's more to talk about, guys. Endochondral will give us these two types of development: primary and secondary ossification. Primary means before birth. We look at the chart there. Secondary means after birth. Common sense. So primary growth is going to give us the shaft of the bone, the diaphysis, the middle of the bone. Secondary after birth is going to be where we develop the edges of the bone and the joints. So think of it, guys. If the joints fully develop in the womb, I don't think that'd be very comfortable because you can't stretch joints that much. You can't sit in a womb. You know, let's be honest. You can't sit in a womb for 6 months, all bent up in a ball, right? So those joints have got to be undeveloped in the womb, and they're going to develop when they get out of the womb. That's what's called secondary ossification. So we'll see a picture here. Keep in mind these two terms belong to endochondral. Don't miss that. Know what each one forms as it's written. Know it's before birth or after birth. So here's our cartilage model right there. We build some bone first. Where do we build it? In the diaphysis region. Before birth or after birth? Before birth. Starting again in the 8th week of development. First trimester. We bring some blood in there, which is when you see a blood vessel come in there, that means good news, more minerals, more calcium. All right, so hopefully that mom is eating right, bringing calcium into the diet. And we'll learn a little bit later today that in order to bring calcium in the diet, we need vitamin D. To put it in real terms, you can eat as much calcium as you want. Is it going to be absorbed? Maybe. What guarantees to be absorbed? The calcium that you're eating? Vitamin D. So the marriage of vitamin D and calcium is what we need to absorb it. You don't have vitamin D, you won't absorb calcium, or it'll be absorbed very little. So that's what we're going to see a little bit later. Anyway, here you go. So notice how we left the edges of the bone alone, because the priority is just the shaft of the bone, the diaphysis. Then after birth, we start doing this. We start building bone at the epiphyses, at the edges. And what's cool is look what's left over, guys. We have cartilage at the edge of the bone for the joint, right, both ends. And we have cartilage at the growth plate. So now you can fully see that it's not that we added cartilage to make that growth plate. This is the cartilage that was always there. We just made bone around it. So you could say, and it might be even worded like this somewhere, you know, in your connect assignments or the test or something, that this is residual cartilage, the growth plate, because it was always there. And that's when it becomes full bone, at least until age 21. What happens at age 21 roughly? to these growth plates. They close up and they'll turn into a solid bone. Yeah. And it will be compact bone. It won't be spongy. It will be a line of solid bone. But we do want to keep that cartilage on the edge of the bone, that's for sure, because that's the muscle joint. All right. Great. So there's your skeleton, guys, of roughly about 12 weeks. Notice anything that's dark. In this case, the coloring is more reddish. Anything that's dark is where we have mineralization of bone. So we have a nice skull formed around the brain, right? It's hardened. The spine is pretty much hardened. That's good. The reason why it's not hardened there on the side of the skull, that bone's very thin. So it just doesn't harden yet. And even look at the lumbar. Lumbar is not fully developed yet either. It's kind of clearish. But look at the joints. The joints don't even show up. So do we have bones there in the joints? We sure do. It's just not hardened. We can't see it. So all the carpal bones are still in that cartilage stage. The elbow bones, you know, the edges, I should say, are in the cartilage stage, cartilage. Everywhere that's clear looking absent is all cartilage. This cartilage is not going to show up here. It's not hardened enough. Everything that is hardened is the darker part. And the kneecap is the last place to harden, actually. So even when your child is born, even in their toddler years, there really is no kneecap hardened fully until later. It's interesting. Yep, so cute. I must say that's wild that y'all can grow that inside you. That's pretty cool. That's up to y'all for growing humans. That's a pretty cool feature. It's true, y'all deserve a medal. Just walking around knowing one day y'all can grow a human with all that intelligence inside, and geez, it's pretty darn cool. Right? Guys can't do anything like that. You guys build the world, make it more beautiful, we tear it apart. So women are great. All right. That's just a review of the growth plate. It's called the line when it fuses. Please don't forget that word. And it's called a plate when it's open. So when I give you my study guides, notice my study guide was really just a bunch of words like the epiphyseal plate. What you're supposed to do with that is write out, this is open residual cartilage, myelin cartilage. Write whatever you can that relates to it, right? And what was the type of growth, by the way, that takes place at the growth plate? Was it interstitial within the bone or appositional outside the bone? Interstitial within the bone. That's how you lock two concepts together for the test. You guys gotta remember, it's not just learning the material, it's knowing how to put it together on the test. It's two different things, it really is. Two different skills. I do not doubt that you guys studied. I know you guys did, I know you did. But maybe you just missed a couple of opportunities on the test to put something together. So you just got to get better at that. It is a process for sure. And the only way to learn it is to do it. That's for sure. It sucks to work through test anxiety, but that's the only way to do it. Because the test ain't going anywhere. You're gonna have plenty of tests in nursing school. You'll get better at it though. All right, so here's our next big topic, guys. Let's see what we are doing on time. We've been going just over an hour. Do you guys want to break before we do hormonal stuff? Yeah, okay. All right, we'll take a break. Besides the anatomy of the bone, where we talked about, you know, all the different parts, and you're going to have that on your quiz, of course, Wednesday. And then we did a little bit about the development of the bone. We saw the cells. We saw the two main types of bone development, and then some for the endochondral kind, there was some before, some after birth. So if we're good with all that, the details of that, remember when you skim these PowerPoints, look for the bold underlying things, you know. And then what you want to do is when you see a bolded word, think, okay, what did he say about that? You know, maybe make a small, try to keep your notes as brief as possible. And the more you can read those notes and then maybe turn the notes over and then put your head back or something, just think about the word or make a list of words on a sheet. And then try to come up with your own explanations of what each of these little keywords meant. How do we put it in the conversation? That's like some, you know, background active studying that would be a good idea for you to do, is to think about it, right? Think about what we talked about if you can. And I know it's a lot, trust me, I do know. The good thing about Unit 2 is that once we get done with this, it's all about labeling bones, labeling muscles, and even though that's a lot, people like that usually because it's something they can hold on to. It's not so abstract. So the coming stuff that we will be doing in Unit 2, naming all the bones and muscles, could be a good thing for you, but again, it's going to be a lot. That's what's intimidating about Unit 2. It is a lot of bones and it is a lot of muscles. All right, here we go. We're gonna finish this chapter up with this topic. So your bone growth will come, it's influenced by, of course, growth hormone. This is coming from the pituitary gland that we talked about and sits in that cell tertia. Well, we haven't gotten it yet, but we'll see that. Sorry. Pituitary gland is the major gland you've got in your brain, in charge of a lot of hormones. So there we go, growth hormone. It's called HGH just because it's human growth hormone, but GH is fine. That's going to give you the amount of bone, the bone mass, you could say, the amount of bone you're going to have. The style of your bone comes from your sex hormones, testosterone and estrogen. Both male and female can produce these. Of course, the male hormone dominant is testosterone, so a female would not necessarily be producing too much of that. Estrogen is the more dominant female hormone. Males typically don't produce a lot of these either, so that's why we develop different styles of skeleton based on those genetics. Of course, that can range, you know, for any one person. There we go. So dwarfism, this will be more so for AMP2. I just thought I'd preview it to you. I'm not going to make a big deal of it for our tests, but there are two types of dwarfism. First of all, the one at the bottom, when it's true pituitary dwarfism, meaning your growth hormone is like very lacking altogether, your whole skeleton will be small and you'll be considered a dwarf when your entire skeleton is smaller, right? But if just the limbs are smaller, notice the difference here. If just the limbs are smaller and you see someone with a normal, what looks to be a longer torso actually, but it's a normal shaped torso, that's a different kind of dwarfism called disproportionate. So if anything, guys, you'll see these two in AMP2 and you'll be tested on them there. I'm not going to test them in our course, right? We're going to worry about the disorders that we're going to have are going to be the osteoporosis, osteomalacia, and some fractures. So that's going to be our focus. So we can skip this for now. Just know you'll hear about that in AMP2 with growth hormone. Okay. That's just all review stuff. All right. So we build and remodel bone based on calcium homeostasis and gravitational or mechanical forces. That's the stress put on bone. So number two is, well, this is the overall heading. What keeps bone healthy? Right. And remember, we got two parts of bone. We got the collagen for the density, and we got the minerals for the hardness. So the density of bone is going to be here, right there. What keeps the density of bone? Number two. How do you maintain number two happening in your life? How do you keep putting force on the bone? Well, one of those is you live on Earth. So, check. Okay, there, right? You live among gravity, which means you've got a natural push. Gravity is not necessarily a pulling force, it's a pushing force. So you're pushed constantly, every day, you're pushed against the gravity here. So that push is, think of, what it means to be, like if you were to go in a circle really fast, you'd be kind of pushed to the wall. Right? So we're being pushed because gravity of the spinning of the earth and everything like that, it creates a force. So that gravitational force is pushing on your bone mass every day. You can't stop it. So you need it, right? That's going to be keeping you healthy with your bone mass. If you went in space outside of Earth without the atmosphere, then you're not going to have the same gravitational force and you will lose bone mass. So those astronauts that live in space, they lose their bone mass. That's why they're constantly having to do exercises, that kind of thing. So mechanical force, what about that? That means how active you are. Do you participate in walking, standing, lifting throughout the day? Yes, right? That keeps your bones active. So basically, it's a use it or lose it. Are you using your skeleton or not? If you're not using your skeleton, then you're going to lose your skeleton. Right? That's what happens when you get older. When you retire, what's the number one thing that happens in retirement? You don't go to work. Therefore, you're not moving around. You're sitting basically, right? Gravitational forces are there, but no mechanical forces. You're not really doing much. So people lose their bone mass in that case. What about the hormonal part, the calcium homeostasis? That's the hardness of bone. That's going to come how much you have dietary calcium going on. And then number two, how much are you actually absorbing that calcium? So again, when you retire, since you're not out and about as much, your range of different foods probably is not there. So people have a very limited diet typically in their elderly years, and they're not getting sunlight because they're not outside enough, so you lack absorbing the calcium. So that's what we're going to see. We're going to have three main players that we're going to see about calcium, but that Wolff's Law, that's what I was talking about. Basically, Wolff's Law tells us, use it or lose it. Bone grows or remodels in response to the demand placed on it. Just like you yourself, your parents probably have given goals for you. If no one ever pushed you in life, especially if you've been in sports, then you're not going to become as great as you could be, right? So bones the same way. They need to be stressed. They need to be pushed in order to keep maintaining themselves and to grow. So that's what Wolff's Law is all about. If you don't grow bone, if you just let it wither away, that's called atrophy. So people that are bedridden, lack of exercise or lack of movement, you're going to lose muscle, but you'll also lose bone. And I don't think I mentioned it, but that growth hormone is also for muscle. So it's bone and muscle growth together for growth hormone. All right, so here we go. How do we maintain calcium? It's with these three right here. Just going to forward to the slide I need, right there at the bottom. Calcitriol, calcitonin, and parathyroid. These are the three hormones used to manage blood levels of calcium, I should say. So when we go through each of these guys, make sure you have in your notes, where do each of these come from? And what will they do? Where do they come from and what do they do? And on the question, what do they do? We want to know, how do they relate to blood levels of calcium? And how do they relate to the bone? So it's a two-part question. When you're answering the question, what do they do? We want to know two things. We want to know, what do they do to the blood? And what do they do to the bone? Okay, so make sure you're answering both those questions as you go through each of these. I'm going to draw something on the board that hopefully will help. A whole lot easier than what it is to memorize it. I'm a picture learner. Sometimes that's the better way to get things. So this can be scary, but it can also be extremely easy if you learn it the right way. I'm going to memorize this bone again, make sure it's normal. Okay, and if you can't see this, because I realize the board's not so great, you can come up and take a picture of it. I'll leave it there. It's going to be really key that you know this picture. So we're going to see how we compare, I should say, how we compare the blood levels of calcium with what's going on in the bone. So there's our bone, right? And here's our blood vessel. Do I need to label that bone? You guys okay? It's important. I'll try to do some different colors here best I can. All right. So we're going to see one method, taking calcium from the blood. I wasn't counting on that. That wasn't me, by the way. Taking calcium from the blood and giving it to the bone, right? I'll remember that sound forever. Then another one, at least it worked. That's what markers should look like. Another one, now we're going to take calcium from the bone, right, and put it in the blood. So see how easy this is to learn it like this rather than memorizing it with words. So practice this a lot. Redraw this. Promise me you're going to redraw this. If not, you're probably going to get it all screwed up. So here we go. We're going to fill it in. Which one takes calcium from the bone and brings it back to the bloodstream? This is going to be parathyroid hormone. So I guess I could throw our hormone in there. Parathyroid hormone takes calcium from the, ultimately, I should say, will take calcium from the bone and bring it into the bloodstream. What takes the calcium from the blood and puts it into the bone? This is going to be calcitonin. So now you know which one does what. We'll chew on that just for a second. Digest it. Need one more color. I don't know if I have another color. I sure don't. Nope. Oh, wait, I do. Still one from main campus. Okay. Now the next one will be a little bit different. The next one we'll see. I'm not sure how well this color is going to show up. But the next one is going to come from our diet, basically. So there's our, that's a log looking stomach. And here's going to be what we're just going to call the small intestine. I'm going to unwrap it. So we're just going to call this the GI. The gastrointestinal tract, stomach and intestine, that's what that's called. In this case, we're going to be taking calcium from the small intestine and putting in here. So you see how we got calcium in 3 different places? We answered the question, where is it coming from, right? Where does calcium come from in this one? Where does calcium come from in that one? And where is calcium coming from for this one? What takes calcium from the small intestine and brings it into the bloodstream is going to be our other one, which you probably haven't heard of before, calcitriol. You have heard of it, but just not by that name. This, guys, calcitriol is vitamin D. So that is why we need vitamin D in our diet. It helps us absorb calcium from the small intestine to the bloodstream. That's what absorption is. You should know. Let me tell you guys the quick difference, because you may not be seeing the overall relevance. This is where it's important, guys. if we did not have vitamin D, if we took it out of business, right? Then what would the calcium do? It would go in the small intestine, through the large intestine, and where would it go?
Out.
Poop out the bladder, right? Do we really want to be pooping out calcium, or better, more so, do we really want a bunch of calcium in our poop? That does not sound very good for the colon, right? Kind of clog things up. So it's necessary we take the calcium from the small intestine and absorb it into the bloodstream. That is necessary. Otherwise, you're just going to poop it out, like a lot of nutrients do. Proof point right here. What happens when you take a cheap vitamin? If you ever see those vitamin things, buy one, get three free. Run. Do not accept that deal. That means that vitamin is going to come right through your stomach, straight to the toilet. When you buy cheap vitamins, they're never absorbed. That's why they're cheap. There's so many chemicals in them to pack them together that tightly in a capsule. They don't absorb in your body. So the good, expensive vitamins are the ones that do have high absorption. That's why they're expensive. Because the technology involved to make them absorbable is expensive. Never buy cheap vitamins. It's a waste of money. Sorry.
I'll be taking the cheapest vitamin D I can find.
Yeah, I don't do that.
So no wonder I have a vitamin D deficiency.
So that's why you need vitamin D. You can't absorb as much calcium as you need. Right, without vitamin D. It's like a friend, right? Beautiful. So this is what we need to know. What does calcitriol do? Does it raise blood calcium levels or low blood calcium levels?
Right.
It will raise blood calcium levels. What does calcitonin do? It lowers. Beautiful. And parathyroid will raise. So we got two hormones, two compounds that will raise blood calcium levels and one that will lower it. Now we're just going to say what's going on, for each of these. Calcitonin, the reason why we're putting calcium in, remember we talked about that matrix, the inorganic part of the matrix? This is what's helping build the bone. This is what's helping mineralize the bone. So calcitonin is used to help build bone or maintain it. Calcitonin is used to help build bone. That's why it's putting that calcium into the bone, right? Parathyroid hormone is a little bit more complicated. Used to tell osteoclasts to take calcium from the bone. To raise blood level. That was a little more complicated. The parathyroid hormone is used to tell osteoclasts to take calcium from the bone and bring it into the blood. So let's talk keywords, right? What's the keyword and used to help build bone? Build. Keyword here, osteoclasts. What I mean by keyword is what's the one word, or sometimes it's two, that you cannot take out. It would kill the whole statement, right? So when I give you a test question about parathyroid hormone, first of all, you're going to know it raises blood calcium levels, clearly. And also you're going to know it's related to osteoclast activity. You cannot take either of those two things out, right? For calcitonin, you're going to know that it lowers blood levels of calcium, and that's used to build. For vitamin D, this is used to help absorb calcium from the small intestine. So absorb is your key word there. Good job. I wish I had me for a teacher. I'm just kidding. No, my teachers just didn't say anything that was important. I think they were only there for their paycheck completely. our college experience was just so mid. It really was. It really, really, really was. Back then, guys, it's a whole different world today. I hate to sound so old fogey, but they really didn't care if you learned. They honestly didn't. It meant nothing to them. That's the beauty of a community college. We actually do care. We really, really, really. I mean, every one of our meetings, we talk about y'all, how much we want to try to fix things to make it better for y'all in some kind of way. So that's the beauty of this environment. So the orange doesn't show up so well, so take a picture when you leave, and make sure you get that. You want to know everything on that board, for sure. It's going to answer all the questions that you're going to be hit with. So learning it that way, drawing that picture would be even better. When you see it in the PowerPoint, it just becomes more scary. I think it's just easier to learn with a picture. Here we go. So make yourself a note card for each of these and get a blank sheet of paper and try to draw this until you get it all. Okay. So now we know that calcitriol is, oh shoot, raises blood calcium levels. Hallelujah. It is known as activated vitamin D. There is a big, I skipped over it when we go back. There is a big sequence that tells us in the body, exposure to sunlight in the skin triggers a reaction in the liver and the kidney to help produce activated vitamin D, which is called calcitriol. So yes, you can get it in your diet. Look at that. Eating milk, fish, cheese gives you vitamin D. That's great, right? Which then will be changed to calcitriol again. So dietary is great too, right? But God's pretty cool. He knows that we don't always eat right? He, she, whatever they did. So skin exposure to sunlight, UV light triggers a reaction. So there we go. So you need both. There's two sources there. Now you know where vitamin D comes from. It comes from the diet or sunlight. In this case, on the board, we wrote the dietary one. I didn't write the sunlight version there. So just know it has two sources here, from sunlight exposure or the diet. Either way, guys, either way, whatever is produced by the liver and the kidney, it's gonna come into the bloodstream. I just didn't include that in the picture, but either way, calcium is gonna get in the blood with the help of vitamin D, okay? So calcium in the bloodstream without vitamin D goes right through the bloodstream, or excuse me, right through the intestine, out the body. Calcium needs to be having vitamin D to help it get in the bloodstream. All right, so there we go. We raise blood calcium by increasing calcium absorption in the small intestine. Same statement we wrote on the board. You can skip all the pictures. If we don't have calcitriol, this is what generally happens. If we don't have it in the diet, because sunlight exposure is just not enough. You got to have some in your diet for sure. If we don't have calcium in the diet, right? If we don't have vitamin D in the diet, excuse me, to absorb that calcium, then we get the deformity of the bones. And this is called osteomalacia or rickets in children. So lack of calcitriol results in softness of the bone. This means that we either don't have calcium at all in the diet, or we don't have vitamin D to absorb that calcium. And the bones do not harden correctly. So and the reason why it's mainly the legs, because we're standing all day. We put stress on the legs. If they're not hard enough, they're going to get bowed. Okay, calcitonin is produced in the thyroid. It's responsible for lowering the levels of calcium by stimulating osteoblasts. What do osteoblasts do? They grow bone, right? So remember how we started with our bone cells? Here's where it's relevant. You got to know what each of these do. And what would it be triggered by? High blood calcium. If the job is to lower it, it's triggered by high blood calcium. That's all your negative feedback again. The last one, guys. Oh, wait, one more thing about calcitonin. It's really only more so important in children. When's the time in our life when we're building the most bone? Right, in the younger years. So children and teenagers, of course, is where calcitonin is the most important. In the adult skeleton, we're not really building that much bone. Therefore, we don't need that much calcitonin. So you really won't see calcitonin levels be high in adults. It's mainly when we're just building bone. But if you think pathologically, if it is high, right? If you go to the doctor as an adult of 35 years old and your calcitonin levels are through the roof, that'd be like really weird. They're going to ask you, wow, did you fracture a bone recently? Are you building some new bone? And you'd be thinking, no. Well, then what's the reason why you might be building so much bone? Why would those osteoblasts be overactive with calcitonin? They could be a cancerous thing. Because cancer cells in bone can be really bad and be too active. So that's where that can be mentioned in an adult, but usually it's only important in children, like this slide says. For parathyroid hormone, this is the more difficult one. It's got a lot of different influence using the osteoclasts. This is the one we had on our test. Do you remember the low blood calcium feedback loop thing? It's triggered by low levels of blood calcium. So what it does is parathyroid hormone, when it's released, when there's low levels of calcium in the blood, it'll be released to stimulate osteoclasts to resorb that calcium and put it into the blood. And here's the little feedback loop that shows it, right? Right. I'll come back to that. Oh, sure. Here's my feedback loop, right? I'll have to come back to it. Right there. So here we go. Low blood levels of calcium triggers an imbalance in your homeostasis. So now we call upon the parathyroid glands. So there's the source to release PTH, the hormone. What does that do? Stimulates osteoclasts to steal that calcium from the bone to put it in the blood. So that's what the whole feedback loop looks like. That was the exact same thing we had on our tests. Exact same question. You just didn't know it yet. All you knew was that it was negative feedback. So even if this is confusing you, remember I told you the slides will mess with your head. If you know what's on the board, you're going to be okay. So let me go back. Okay. So why is it, this slide is just to give you some importance here, what calcium is doing. Why are we desperately concerned with calcium levels in the blood? We know it should be in the bone to harden it, yes, but why are we also concerned about calcium in the blood? Here's the reason. And you don't have to know this whole slide, it's scary. Like I said, this is what AMP2 looks like. What we want to know is that low levels of calcium means you'll get spasms. Your muscle needs calcium, if you didn't know this, to work. So if you have a spasm in your larynx, which is your voice box, right, around your throat area, that's pretty scary, right? That could be life-threatening because that controls the air going into your lungs. We never want spasm in the muscle here. We certainly don't want spasm in the heart. That doesn't sound good, right? All muscle can become spastic. It becomes irritable and overly excited. What happens when you're hungry, guys? We're irritable and overly excitable, right? Yes. Irritable and twitchy, right? I've learned one of the most valuable things I ever learned is that in all the times I've ever been with a woman, I mean, just hanging out, when they're like radically like irrational. Oh my God, what did I do? I didn't do anything. I just showed up today and I'm just sitting here. It's usually because they're hungry. So the first thing I do now is, baby, you want something? No, that fixes everything, right? You guys are a whole lot more peaceful when you're well fed. Other than that, man, don't tell them what comes out. So just know that when we're low on calcium, it's kind of like us. When we're low on energy, we're irritable and twitchy, right? So spasms is the big thing for low blood calcium. Hypercalcemia means it kills the muscle. They don't work at all. So too much calcium means muscle weakness, like cardiac arrest. That does not sound good at all. So too much calcium, no response from muscle. Too little calcium, irritable and twitchy or spastic muscle. Okay, try to make it that easy. And you'll have to remember this for AMP2 also at some point. Okay, any questions on that? Low calcium is spasm. High calcium is weakness altogether. And if you're curious, it's the exact opposite. Split this for potassium levels. And that's what you get with potassium levels high and low. Okie dokie. All right, so there's our review. We need growth hormone, of course, to build the bone, testosterone, estrogen to style the bone, and all those hormones to for maintenance. And here's a review of those, of two of those, PTH and calcitonin. Okay. Any questions on this? Like I said, it's probably easier to learn it based on the board than it is in the PowerPoint. But if I shot you a couple of quick questions, which one is important in children? Primarily. Calcitonin, because you want to build bone. That's the reason why, right? Which one uses the osteoclast? Parathyroid. Which one is involved with absorption of calcium in the small intestine? Calcitriol, right? Very good. That's the little buzzwords you want to get to use, right? Which one is used to build bone? Calcitonin. All right. Which one lowers blood calcium levels? Calcitonin. Which two of the three raise blood calcium levels? Calcitriol and parathyroid, right? So that's how you do it. And one last thing in the matter of feedback, check it out, guys. I know you can't see it very well. In the orange is where we have our vitamin D, calcitriol. If this was doing good, if we got good sunlight exposure and good dietary vitamin D, if all of this is good, right? Having calcium in the bloodstream at a good level, if this was happening all good, then we would not even need parathyroid hormone, would we? So what's better for the body? To have it in the diet and sunlight exposure, or to steal calcium from the bone? Have this. So when we have this all together, we don't even need this. So we get to help the bone. So we inhibit osteoclasts by increased vitamin D. Does that make sense? If you ever got something like that in AMP2, that's where they're leading you. What would inhibit osteoclasts? Having a good calcitriol, good vitamin D, because it would cut this whole cycle out. We wouldn't need to steal calcium if we were getting in the diet. And that, by the way, is what happens with osteoporosis and osteomalacia. People that don't have it in their diet end up stealing too much calcium from the bone. All right, that pretty much puts us to the last part of the chapter with fractures. Now, you guys are probably going to need to learn these at home because it's after all that hormone stuff, you probably don't have any more space in your brain. But here we go. We'll talk about one by one. Out of all these pictures right here, which bone looks like it's out of its normal placement? That one right there in the middle. Right? It's out of its normal placement. That's what displaced means. So out of all these, the one that's in the very center is the displacement. The other six, the one on the right and left, 3 and 3, those are the non-displaced because they're in their normal placement, aren't they? What about complete versus incomplete? Which one is broken in two complete pieces? Again, the one in the middle. So when you have a bone that's broken, it can either be broken and still connected like this, or broken in two complete pieces like this, separated, and that will be complete. When the two pieces are separated, it's complete. When the two pieces are still linked together, it's called incomplete. So we can have lots of versions of incomplete fractures. You can see some of them here, right? Lots of versions can be incomplete, where they're still connected. But if it's ever fully separated, it's called complete. Linear versus transverse just points to if the break or fracture is up and down with the long axis of the bone, that will be linear. Or if it's across, that's transverse. Or in the case of the one in the middle, that's oblique. So those words, have to do with the shape as it's crossing the bone or going with the long part of the bone. Then we get this one, compound versus simple. This refers to, did it break the skin or not? So if the bone poked out of the skin, that is a compound fracture. If the bone broke but stayed within the skin, it's called a simple or closed fracture. So those have two names, either open or closed, opening the skin or closed, or the skin closed, or compound simple, same thing. And by the way, a fracture is a break. There's no, the statement, oh, I didn't break the bone, I just fractured it. That doesn't make any sense. A fracture is a break. Of course, it could be, mild or severe, but a fracture is technically a break in the orientation of the bone, right? And there's lots of different ways, as we're seeing, and that could be done. So here's the same old pictures. So on the left, transverse, right? Linear up and down, oblique, kind of diagonal. Displaced oblique would be, and that's of course separated, so that's complete. So the middle one is oblique, displaced, complete, to be honest. We don't know if it broke the skin or not, so because we don't see any skin. But if it did break the skin, it would be compound or open, right? And then another example of an incomplete is a green stick. And usually that means a little fracture on one side. Comminuted is the last one. That's when it breaks into small fragments. Like if somebody hits your bone with a hammer, that'd be where it crumbled the bone, let's say. Or with osteoporosis, to be honest, with a lack of density in the bone, these kind of fractures are pretty common. They break into fragments because there's nothing to hold the bone together. And just some examples of fractures here. Nothing on the test on the x-rays, of course, but it's just always fun to see these. This is a very common thing that happens in car accidents or gymnasts, people landing their feet wrong, it crumbles the bones together. That is a crumbled vertebra, a compression fracture. This person could have maybe sat down and somebody moved the chair and they fell flat on their butt, or they slipped and fell on their butt, or they were in a jet ski, hit a bad wave, or in a boat with a bad wave. That can do it. Or the most common is riding horses. If any of you guys ride horses, this is a common thing with all that, because people fall off horses all the time from very young ages. These vertebrae do heal, but they also become misshapen when they heal. There's a growth plate fracture, so that would need to be pinned together. That's a very ouchy one. This person here, a compression fracture on the skull, a depression rather. Maybe he had a stapler thrown at him or something. He probably didn't take out the trash, that's what it was. I've had three staplers thrown at me before. I think I'm good at dodging staplers. Never be around a woman with a stapler. No, one of the little laws in my head. Come to know that. You guys are lots of fun. Green stick again right there. Look how passionate y'all are. Okay. Yeah, there we go. So the one thing about healing, don't have to know all these sequences going on. You just have to know that we form what's called a bony callus. Where the bone is broken, it will heal stronger. So just know that term, a bony callus, means this is what happens when you heal bone. It forms back stronger, known as a bony callus. So on X-ray, if you're going that way, when you see something of a bright line through the bone and it's not a growth plate, that's probably where something heals. They broke a bone somehow and it can heal. Or if it looks a little more swollen, a little more widened at that area of a long bone, that means they had a break there at one time. Now, of course, there's a whole range of bone cancer going on where you have to differentiate that, but in this simple case, it's a fracture that's been healed. Cancerous bone is going to look like a lot of holes, like a lot of blackness in the compact bone. You don't ever want to see black areas in bone. That's not a good sign. Or if it looks like something just blew up on the side of it, that's not a good sign either. It's bone cancer looks pretty nasty actually on X-ray. Last thing, guys, last thing at all about this is whether we have an open or closed reduction. This involves surgery or not. So let's say we can manipulate those bones. We can put them back in place without surgery. That's called closed. Or with surgery using screws and plates and pins. That's called open because obviously it had to open your skin to get in there. So let these words be very common. Open means you opened the skin and went in there and fixed the joint, or fixed the bone.
If they,
So this would be an open reduction.
is it still considered open if they have to open it, but they don't press hard nurse?
Yes, it is. Yeah. That's what actually, not what she said, but my first encounter with me being influenced to want to be a bone doctor was I broke my wrist skateboarding. Which one was it? No, actually both. But I think it was my right one. Yeah, my right one, where the dude the ER doc just manipulated the bones back into place in my wrists. I was in love, at that point. Not with him, but with the idea. That was like really, really cool. That left a huge impression on me. And I got a Happy Meal that day. So that was a really good day for Michael. Got to miss school. It was great. Happy Meals used to be like 99 cents. So
They're almost $11.
I know. I went to Chick-fil-A. The darn kids meal there is like $7 now. Crazy. Yeah. Yep. Okay. The difference between porosis and malacia. Where did it go? No, we don't need to know that yet. Oh yeah. Porosis is a bone density issue. So there's your keyword for osteoporosis. Lack of bone density. So look at the statement. That means a lot. Estrogen helps to inhibit osteoclasts. So what happens when you take estrogen out of the mix hormonally? It means osteoclasts are free to roam. So if you're not getting your dietary calcium with vitamin D, those osteoclasts are going to keep stealing calcium from the bone. So this is where osteoporosis does become about calcium. It's not just about the collagen. So that's what osteoporosis looks like right there. All the holes in the bone that you don't want. And this is a common fracture with osteoporosis. A simple fracture could be grandma stepped off the curb. She lost her footing, hit the curb wrong with her heel, stepping off. And that, just that small amount of force, could cause a fracture because the bone crumbles like that. See, with Malaysia, guys, you have plenty of density. There's no holes in the bone with osteomalacia, but the bone's just not very hard. So it can mold and deform. With porosis, the density is gone. So it crumbles. Okay, that is the absolute end of this chapter. We do need to start at least our skull conversation. So we're just going to be learning the bones of the skull for today. And then our Wednesday will be a very, very busy day. We're actually going to do the skull and part of the arm. So it's going to be a very, very hot day for Wednesday. But I'll let you know about the test, but I do want to take about 20 minutes or so and cover the bones of the skull with you guys. Because we need to get at least that started, okay?